Age-adjusted breast cancer mortality is about 40% higher among Black women than among non-Hispanic white women in the United States, despite a lower incidence of breast cancer among Black women. This disparity has persisted since death rates diverged in the 1980s. I'm Stephen Morrissey, managing editor of the New England Journal of Medicine, and I'm talking with Ismail Jatoi, chief of the Division of Surgical Oncology and Endocrine Surgery at the University of Texas Health Science Center at San Antonio. Dr. Jatoi has co-authored a perspective article about racial disparities in breast cancer mortality. Dr. Jatoi, could you describe the current race-based differences in breast cancer incidence and mortality in the United States?
I'd like to begin also by first acknowledging my co-authors, Dr. Ahmadine Jemal and Dr. Hayuna Sung from the American Cancer Society. This was a collaborative effort, and certainly their input into putting together this perspective was an integral part of what we had to bring together in terms of this article. But in terms of the difference in mortality, what we're seeing is, as you point out, a 40% increase in breast cancer mortality among Black women in the United States in comparison to white women. And yet there's a 10% lower incidence of breast cancer in Black women. Now, what's interesting also is in this article, we looked at incidence-based mortality with regards to estrogen receptor, and then when we compared those differences as well. So, for example, the estrogen receptor positive breast cancers have about a 21% lower incidence in Black women, but the mortality is about 19% higher. 65% higher rates of estrogen receptor negative breast cancers in Black women, but the mortality is more than twofold greater.
So you write in your perspective article that before 1980, breast cancer mortality was actually slightly lower among Black women than among white women. So what changed in the 1980s that led to the rates of death decreasing faster among white women than among Black women?
I think there are two important observations that come into play here in the 1980s. One, as you point out, we see the divergence in breast cancer mortality between Black and white women. And shortly after that, we see for the first time a reduction in breast cancer mortality overall in the United States. So it's important to keep in mind that breast cancer mortality rates in the United States have been flat for many decades. Then all of a sudden, in the late 1980s, early 1990s, we witnessed for the first time reduction in breast cancer mortality. And we've seen since that period about a 40% reduction in breast cancer mortality overall in the United States. That divergence in breast cancer mortality between Black and white women became evident shortly before the mortality rates started to decline. So now what precipitated this? We can do what's known as an age period cohort analysis. So we can look at trends in mortality according to age. We can look at changes in mortality according to the year of death. We refer to that as calendar period effects. We can look at changes in mortality according to the year of birth of the different cohorts. We refer to that as birth cohort effects. And what we see when we use this modeling technique, and I undertook those studies back in 2005 with collaborators at the National Cancer Institute when I was in the military. But when we looked at those models, what we found is that there's a divergence in breast cancer mortality according to racial groups based on calendar period, but not according to birth cohort. Calendar period effects largely reflect introduction of new medical interventions, whereas birth cohort effects reflect the variations in risk factors among people born during different eras. So the divergence in breast cancer mortality is almost certainly due to introduction of novel medical interventions in the 1980s. And as we point out in our article, there are two medical interventions that were widely implemented for the management of breast cancer in the 1980s, mammography screening and adjuvant endocrine therapy. And both these interventions, as we point out, primarily benefit patients with estrogen receptor positive breast cancers. And Black women have higher rates of estrogen receptor negative breast cancers. And also, I think a big part of the divergence in racial disparity has to do with the access to these interventions. Black women have had less access to these interventions when compared to white women. And so we've seen the emergence of the disparity as a result of the introduction of these interventions and issues pertaining to access, where Black women have a disadvantage in terms of access, and also because Black women have higher rates of estrogen receptor negative breast cancers, and these interventions predominantly benefit patients with estrogen receptor positive breast cancers.
Do similar disparities exist for other cancer types in the United States?
There are disparities, of course, with many different cancer types. We focused here on breast cancer. This emergence of this disparity that we've described here, I think is fairly unique to breast cancer. Breast cancer, as we point out, we've made tremendous progress since the 1980s in terms of treatments. But this disparity between Black and white women has persisted, which I think emphasizes this whole issue of access to care and being able to provide good care and universal health care is obviously an important means, will be an important means in the years ahead of narrowing that gap in mortality disparity.
So moving forward, what kind of research do you think is necessary to help eliminate this mortality gap?
I think there's two very important issues that need to be addressed. First, universal access to healthcare, I think, is going to be key to eliminating mortality disparities, not only in breast cancer, but the cancers as well. Certainly, I think our studies suggest that this is something we need to address in the years ahead. The other very important point, I think, is the fact that we have to make better progress in treating estrogen receptor negative breast cancers, and particularly triple negative breast cancers. As we point out in our article, Black women have 65% higher rates of estrogen receptor negative breast cancer than white women, and 81% higher rates of triple negative breast cancers. Triple negative breast cancers tend to be very aggressive. They tend to occur in younger women, and they contribute enormously to this mortality disparity. So research into the treatment, into the etiology of triple negative breast cancer, I think needs to be a national priority, not only for reducing the overall burden of breast cancer mortality worldwide, but also narrowing and eventually eliminating the racial disparity in mortality.
So finally, going back to the issue of access to care, what policies do you think would help increase access to care and reduce breast cancer mortality among Black women?
Well, I think the emphasis should be on access to high quality medical care. And we see, for example, oftentimes in my own practice, patients have problems getting into the system. There's delays in terms of getting funding. And as a consequence, there's delays in initiating good quality, timely care for patients. So universal healthcare access, of course, would eliminate a lot of that. So I think that will remain an important goal. Getting back also this issue of estrogen receptor negative, triple negative rates being higher among African Americans. This, as we point out in our article, I don't think is primarily a hereditary issue. What many studies are now showing is that the rates of ER-negative breast cancers are declining, but the decline is uneven. So parts of the United States where women are less affluent have slower rates of decline in ER-negative breast cancers than the more affluent rates. And this applies to white women as well. So white women from poor areas have seen slower declines in ER-negative breast cancer rates than have white women from more affluent areas. So clearly there are socioeconomic factors involved here. There's structural racism involved here. All these factors have had important effects in, I think, the disparity in triple negative breast cancer rates being more common in Black women. And certainly the universal access to healthcare has contributed also to the disparity because Black women have had less access to timely, high quality medical care.
Thank you, Dr. Jatoi.